Sarcoidosis, a multisystem granulomatous disease, presented by Dr. Kamran Chaudhary, MD, Pulmonary Medicine. Definition: what is sarcoidosis? Sarcoidosis is a multisystem granulomatous disease of unknown etiology, characterized by non-caseating granulomas. Most commonly affects the lungs and intrathoracic lymph nodes, can involve almost every organ including skin, eyes, heart, liver, nervous system. History: the term sarcoidosis is derived from the Greek word sarcoids, meaning flesh-like. First described by Jonathan Hutchinson in 1877. Epidemiology: peak incidence 20 to 40 years, more common in women. About 50% of patients are asymptomatic, often detected incidentally on chest X-ray. Clinical features: respiratory symptoms, dry cough, dyspnea, chest pain, constitutional, fever, fatigue, weight loss, extrapulmonary, skin lesions, eye involvement, cardiac disease, neurological manifestations, classical syndromes, Löfgren syndrome, bilateral hilar lymphadenopathy, erythema nodosum. Acute arthritis, especially ankles, often does not require biopsy if clinical picture is classic. Heerfordt syndrome, Heerfordt-Waldenstrom syndrome, anterior uveitis, parotid gland enlargement, facial nerve palsy, fever, often included as the fourth feature, radiological staging, Scadding classification, chest X-ray staging, stage 0, normal chest X-ray, stage 1, bilateral hilar lymphadenopathy, BHL, stage 2, BHL plus pulmonary infiltrates, stage 3, pulmonary infiltrates without hilar adenopathy. Stage 4. Pulmonary fibrosis. Diagnosis: required compatible clinical presentation and histological evidence of non-caseating granulomas. Exclusion of alternative diagnosis. Biopsy: tissue diagnosis biopsy is recommended in most patients, except classic Löfgren syndrome and classic Heerfordt syndrome. Preferred biopsy techniques: EBUS-TBNA preferred over conventional TBNA, transbronchial lung biopsy, TBLB, endobronchial biopsy, histology showing non-caseating granulomatous inflammation. Laboratory findings: investigations elevated, serum ACE raised in approximately 60%, hypercalcemia, hypercalciuria, ESR may be elevated, MAN2 test, usually negative because of anergy, bronchoalveolar lavage, BAL findings, lymphocytosis greater than 15%, CD4/CD8 ratio greater than 3.5 supports diagnosis. Pulmonary function usually shows restrictive defect, reduced DLCO. DLCO decreases early in pulmonary disease. Serum chitotriosidase, normal 40 to 120 nanomoles per milliliter per hour, elevated 200 nanomoles per milliliter per hour. Sensitivity, approximately 80 to 85%. Specificity, approximately 70 to 90%. Treat only when symptomatic pulmonary disease, progressive deterioration in lung function, radiological progression, cardiac sarcoidosis, neurosarcoidosis, ocular disease threatening vision, hypercalcemia or hypercalciuria, significant skin disease, other critical organ involvement. Corticosteroids, first-line therapy, prednisolone, initial dose 20 to 40 milligrams per day, continue for 4 to 6 weeks, then taper gradually. Total duration, usually 6 to 12 months, depending on response. Steroid-sparing drugs, immunosuppressive agents, methotrexate preferred, 10 to 15 milligrams per week, increase up to 25 milligrams per week. Most commonly used steroid-sparing agent, leflunomide, 10 to 20 milligrams per day, useful alternative to methotrexate. Mycophenolate mofetil, 2 to 3 grams per day, particularly useful in neurosarcoidosis and when methotrexate is not tolerated. Biological therapy, anti-TNF therapy, infliximab, 3 to 5 milligrams per kilogram IV, given at week 0, week 2, week 6, then every 4 to 8 weeks, usually continued for 6 to 12 months. Best evidence in refractory pulmonary sarcoidosis, neurosarcoidosis, cardiac sarcoidosis. Rituximab, dose, 1 gram IV. Repeat after 2 weeks, day 15. Further dosing only if relapse occurs, reserved for selected refractory cases.